on the line. Good afternoon, everyone. This is Giovanna Giuliani from the California Healthcare Foundation. Thank you so much for joining the monthly CIN webinar. And the topic of today's webinar, as you can see, is the HomeMeds program, a medication management improvement program. And before I go on, I just wanted to ask folks to take a second. There are 3 poll questions on the right side of your screen. You may need to expand the polling section. It may be at the bottom of your screen if your chat function is expanded. But just please take a moment now to answer those 3 brief questions in the polling section. So as I mentioned, today's webinar, monthly CIN webinar, is on the HomeMeds program. And we thought this would be of interest to the CIN audience because as we all strive to care for patients with chronic disease, and especially during care transitions and those with multiple chronic conditions, we always hear providers and organizations talking and facing the need for processes for medication reconciliation, for medication safety improvement. And what we feel is unique about this approach is that it can really be integrated. It can stand alone, but it can also be integrated into your existing care management processes that you already have in place, and care transitions processes that you may already have in place from hospital to home or hospital to nursing facility. And hold on just a second. A few housekeeping items before we continue. This session is being recorded, and we often get questions about whether or not the recordings and the slides will be available after the presentation, and indeed they will be. They'll be posted on our website within a week. If you registered for this webinar, and you probably have since you're on the phone and we have your email address, we also send an email out to those who registered with the slides and with the link to the recording so that you can pass it on to any colleagues or for those who registered who didn't call in. If you have a question, please feel free to ask your question as we go throughout the presentation. Sandy is happy to entertain those questions. So you can use the chat function on the right-hand side. Please chat questions to everyone so that everyone on the webinar can see your question. Also, Sandy will not be sort of multitasking, and so if you chat your question to Sandy, she probably won't see it. So Canel and I will keep tabs on those questions that come up. Before I introduce Sandy Atkins, our speaker for today, Sandy is the Project Director and Vice President of the Institute for Change at the Partners in Care Foundation. They developed the HomeMeds program. I wanted just to take a moment to highlight for those of you on the webinar that we are announcing a new CIN website. It went live yesterday, I believe. And so I just wanted to make sure all of you were aware of this new resource. We had an old site, and this is now kind of refreshed and has some additional resources on it that I wanted to make sure everyone was aware of. And let me see if I can find the pointer. There we go. So you'll see on the left-hand side there are our 4 key areas that the California Improvement Network offers, the webinars, which are why we're all here today. We have our workshops, which tend to be focused on quality improvement methodology, and those are in-person convenings. We have the quarterly partner reports, and those are kind of the summary and learnings around particular topic areas that come out of our partner in-person meetings, and those are quarterly. And then the last area that's new are these action groups, which are what we're calling micro networks. They're short-term, 6 to 9 months virtual networks where we have several organizations coming together around a particular topic that they're trying to improve or they're trying to solve for their organization. And we have the first one launching in August around reducing variation. And so what you'll see as time goes on, if you're getting the California Improvement Network emails, is you'll see announcements for additional action groups starting and opportunities to apply for them, opportunities to suggest topics for action groups. If you wanted to convene organizations that were like-minded and similar to yours that wanted to get together and talk about a particular topic, you could make recommendations for those as well. And the foundation can select among those ideas, and they would provide project support to bring these individuals and organizations together virtually. So that is our first one's being tested. So we're kind of seeing how it works, just as we encourage other folks to test new ideas. We're testing out this approach now, and what we learn from this first action group iteration will be applied to future action groups. And then just to highlight in the middle under upcoming events, you can see our upcoming workshops and our upcoming webinars, and there's the one that we're on today. On the right-hand side is where you will see the webinar recordings, the most recent webinar recording. And then the last thing I wanted to highlight is this required reading section, which is kind of a seminal reading, a 101, the basics, for 3 topic areas the Foundation has been focusing on for the past several years that we felt we could do a good job of bringing together kind of the seminal reading in those areas. And so that is complex care, palliative care, and the patient experience. So if you want to kind of go and check out what we have, those are the 3 first areas that we've tackled in terms of saying these are the top 5 to 10 resources. If you wanted to get up to speed on a topic very quickly, you could visit this area for these 3 content domains. Now I am very happy to introduce Sandy Atkins. As I mentioned, Sandy is the project director. She's the vice president for the Institute for Change of the Partners in Care Foundation. In this role, she directs the HomeMeds program, research and consulting, and new initiative development. Sandy also served as the executive director of the Hospice of Pasadena. At the USC Andrus Gerontology Center, she directed the Center for Long-Term Care Integration, which was a state-funded effort to help counties integrate medical and long-term care systems for the dual-eligible population. She's also directed the Minnesota Rural Elder Services Community Initiative, and before that, she was administrator of several continuing care retirement communities. Sandy has a University of Arizona Master's in Long-Term Care Administration and Gerontology, and also a BA in Spanish from SUNY Buffalo. So thank you, Sandy, for joining us today. I am going to get your presentation started and give you the ball. Okay, there you go.
Great. Well, thank you so much. It's lovely to be here, and I appreciate the opportunity to tell folks about what we're doing. So let me just launch right in. Oh, let me just make sure that I'm doing the slides right. Okay, there we go. So as a background, I see that people are from a variety of kinds of organizations. Most of you probably already know the extent to which medication errors, medication problems are serious. We've got over 700,000 people going to the emergency room every year for the results from drug problems. This isn't drug abuse. This is just regular prescription medications. They're also very costly. We're talking about billions of dollars because of the emergency room use, hospitals, readmission, getting rehabilitation, all of that. They're very common. Our research and other research has found that up to 48% of community-dwelling older adults have medication-related problems. I'm focusing on older adults because that's the population where we have tested our intervention. And luckily, distressingly, but luckily, a lot of this is preventable. So that's what we're focusing on because we want to work on that prevention. HomeMeds is, this says the solution, obviously it's a solution. And what we're doing is we're finding community agencies where folks are already going into the home and engaged with our older adults and helping them keep their clients out of the hospital, at home, safe, and out of the nursing home. This was designed by pharmacists and under a national consensus panel that included Mark Beers, who is renowned for the Beers list of medications that are, you think twice about prescribing these medications for people 65 and older for a number of reasons. And we chose these problems, which I'll go over in detail later, because of their significance, their accessibility to discovery by in-home staff, and the likelihood that prescribers would respond positively. So we're looking for potential adverse effects. So it's a little different from what you think of as a pharmacy-based system, because they are looking at medications and combinations of medications. We are looking first at potential adverse effects, like this person has had a fall, their blood pressure is way too low, or they're getting dizzy when they stand up, or they're confused. And then we're looking to see if medications could be a cause. So it rather flip-flops the logic of a lot of medication safety interventions. The core components of our program include in-home collection of a comprehensive medication list, with an interaction where we ask the client or their family, if they're not capable of reporting for themselves, how are you taking this, when are you taking it, why are you taking it? Plus, we're collecting other information like vital signs, fall history, other symptoms, and indicators of adverse effects. We use our evidence-based protocols to screen for risks and use that screening to most appropriately deploy consultant pharmacist services, and using a computerized medication risk assessment to do that. And that produces alerts, and it also contains a comprehensive reporting system for interaction between care managers, pharmacists, and others that are involved in the care of this patient. And very importantly, we involve the consultant pharmacist in the whole intervention to do a lot of the interaction with prescribers, using the care managers and the pharmacist to interact with the patients. So just our little quote here is, any symptom in an elderly patient should be considered a drug side effect until proved otherwise. And it's just, people don't think of it necessarily. Why is this person confused? Why is this person tired? It just seems like part of aging, but very often it really isn't part of aging. It relates to the medications that folks are using. And we use HomeMeds especially as we're a nonprofit organization, and we're using HomeMeds to bridge between the home, where people make all of their decisions about their day-to-day health, and health care, where the recommendations and the prescriptions come from. So HomeMeds is an excellent way to have a window into the home to health care, and a way of communicating back to health care from the home. Most of our agencies that are using HomeMeds are non-health providers. They're area agencies on aging and Meals on Wheels programs, all kinds of different organizations. And very often I start by telling them, well, why should these agencies be working on medication safety? And part of it is that to thrive in the new world of these community-based organizations need to play a new role. And actually CMS recognized that new role by including these community-based organizations as the primary providers of care transitions, for example. So it's important for them to know that medications are a major factor in readmissions. The home provides a unique perspective that is otherwise unavailable, and I have a slide later that talks about all of the different things that we find in the home that the providers don't know about. All around the country, we're focusing on population health and proactively addressing health for high-risk patients. This is a way of finding out who is at high risk for medication problems. There's quality measures totally related to what we're doing. So they're related to falls, they're related to cardiac symptoms and cardiac management, medication management, and those are all things that HomeMeds is responding to. Medications and care transitions are a huge issue. Over 20% of discharged patients have an adverse event, and 72% of these are medication related. And so all of the care transitions, interventions, programs that are out there have an element of medication reconciliation and risk assessment. In some cases, it's done in a purely coaching approach. Other cases, it's done professionally. And we are consistent with all of those practices. But in addition, we say, why wait for hospitalization? Why not intervene earlier, which is our underlying philosophy. Because what we find is that people tend to think of over-the-counter medications as being totally safe, and anything that's available in the drugstore must be fine for me. We find lots of duplications and counter indicated over-the-counters. We find people have prescriptions from all kinds of providers that aren't known within their healthcare system or by their primary care providers. We find that they report to us adverse effects that nobody else is asking about even, let alone knowing about. So falls, dizziness, confusion, and they do take vital signs in the doctor's office, but there's a lot that we find out in the home that they will never know. Adherence issues, so I'm not taking that because I don't like it, I can't afford it. It says to take it with meals, and I don't eat often enough to take it 3 times a day. There's all kinds of issues with adherence. And then also, you know, we're getting into an era where actually the co-pays for what you get from your health plan may actually be more than Walmart is charging for the same medication. So there's lots that people think are in the system, even if they're computerized, but really aren't. In addition, people are getting, you know, medications from other countries. They borrow what works for their brother or sister. And so there's a lot in the home that people don't know about. We have lots of quality measures. I mentioned these before: review of medications, pain screening, blood pressure control, reducing risk of falling, hospital readmissions, drug-disease interactions. All of these are important now to healthcare, and a reason why the relationship between the community organizations that are seeing seniors in their homes and the healthcare organizations is a really important relationship and becoming more important over time. We find that because we're relating directly to people that have had falls and other adverse effects, that we feel that the return on investment is really significant. I've talked to some of the major researchers in medication therapy management, and they agree that what we're doing is like a highly targeted medication therapy management, but it's originating in the home and community rather than originating from the computer of a Part D plan. So in 7,000 screenings, we estimated that probably saved the healthcare system probably $1 million or more. So the theory behind what we're doing, and not just theory, but our research backs this up, is that if we improve medication use, we'll have fewer falls, improved blood pressure control, less confusion and other adverse effects, and therefore lower cost, which is the triple aim that everybody is aiming at these days. So quickly, having gone through that, let's talk about what is HomeMeds. So the first thing is what I call a treasure hunt to find the hidden medications, everything that's in the home, asking, let's go room to room and make sure that we're catching everything that you have next to your easy chair, next to your bed, in your refrigerator, in the cabinets, in the drawers, and really trying to find everything. Then transcribing that accurately from the bottle or the box into our software, and then in addition to what's on the bottle, asking them, what do you take it for? When do you take it? So we're finding adherence issues. I mean, typical things would be, this says take 3 times a day with food, so I eat lunch only. I'm taking 3 pills with my lunch. And we note all of those things in our software. And what happens when they take, do you have side effects? Is it working for you? So it's a dialogue about adherence as well as this inquiry into whether the medications themselves are the right medications and whether they're causing problems inadvertently. And then, of course, the assessment I've discussed. So this is considered an evidence-based program, and it originated with a Vanderbilt University study funded by the Johnny Hartford Foundation, our good friends and supporters. And it was a randomized controlled trial in home health where a pharmacist-nurse collaboration was used to identify and resolve errors. In that population at that time, we found that about 20%, 19-20% of the people had potential medications, and the intervention improved medication use in 50% of patients that were in the intervention compared to 38% of controls, which is actually about a 50% better performance than just usual care in home health. And the history of HomeMeds came from home health nurses saying, you know, I just can't keep up with all the changes in medications and, you know, what works with what. So the pharmacist was a huge addition, and it was an innovation through the Visiting Nurse Association of Los Angeles, which is Partners in Care Foundation's original source. So we became Partners in Care Foundation from the VNA of Los Angeles. Further evidence, we then researched home health is one kind of program, but we also wanted to look at an intervention that uses social workers as well as nurses, and we looked at our Medicaid waiver for dual eligibles. All of these people are nursing home eligible seniors living at home. So the social workers and nurses collected the data in the home. And in this population, the other one was home health, which tends to be post-acute. This one, about 50% of them came screened in with potential medication problems, and almost 30% of all of the waiver clients required a physician intervention. And we were happy that medication use improved in 61% of the clients who had problems that were taken to the prescriber level. So we get a good response from prescribers when we bring things to their attention. We focus very heavily on making sure that what we take to the physician is meaningful, having been pre-screened by a pharmacist, and we're finding a lot of problems. Some of the problems can be addressed by the pharmacist and the case manager, dealing with the patient and giving them advice about their use of over-the-counter medications. Others require an intervention with the physician and their prescribing. Now, not every problem is going to wind up with a change in medications. Sometimes a patient will refuse. Sometimes the physician will say, you know, in essence, we've already tried every alternative to this medication. It's the only thing that works. We know what the risks are, and we just have to accept those. So we have been recognized by the Administration on Aging as one of their highest level of evidence programs that's incentivized for use in what we call the aging network of agencies. The Administration for Community Living just released a new program that's called the Aging and Disability Evidence-Based Programs and Practices Center, and they rated our research and our dissemination and found that we had a very high quality of research, and that out of our readiness for dissemination, which means our support for adopting agencies, was a 4 out of 4, which makes us pretty proud. And then also the U.S. Agency for Healthcare Research and Quality, AHRQ, includes us on their Innovations Exchange with a strong evidence rating. Here are the protocols. This is what we're looking for. I've described again that, you know, we're trying to minimize alert overload by focusing on issues that have happened, that we can verify have already happened. So we're looking through our software for unnecessary therapeutic duplication. And there are duplications that are necessary, so we try to make sure that we're eliminating any duplication that's, you know, an as-needed medication for breakthrough pain in addition to a regular pain killer will not be considered an unnecessary therapeutic duplication unless the patient is taking the as-needed all of the time, in which case you actually are getting double, and they should probably have a review of their symptoms and their medications. Then we're looking for has there been a fall, or is there confusion that's uncharacteristic for this patient? And then looking to see, are they taking psychotropic, psychoactive medications that might be related to those? And one of the most common ones that people are using, there's sleeping medications, but the over-the-counters, Advil PM, Tylenol PM, those are included in those because they have a sleep-inducing and therefore a fall, potentially fall-inducing effect. Then we're looking for very high risk for the use of NSAIDs, non-steroidal anti-inflammatory drugs, which would be things like aspirin, ibuprofen, and Aleve, naproxen type medications. In people that are over age 80, even though we may be bringing that threshold down because actually the label starts at about age 50, we don't want to go overboard because people need something for their pain. So we're trying to find people at high risk for peptic ulcer or gastrointestinal bleeding, which would also mean if they're taking NSAIDs and also taking blood thinners, warfarin, those kinds of things, antiplatelet medications, or have a history already of gastrointestinal bleeding. The final group of problems we're looking at are cardiovascular. So we're screening for continued high blood pressure, even if you already have blood pressure medications, a low pulse related, for example, to beta blockers. This is one that I was suffering from. I had no energy, and I'm wondering what's going on, and I finally noticed that my pulse was 44, and they changed my meds, and all of a sudden I was a new person. So putting that on somebody who's age 80 makes a big difference too. We're also looking for orthostasis, which is that sudden drop in blood pressure when you stand up. So that's about a 20 point drop in systolic blood pressure, and also looking for low systolic blood pressure, which might mean they're actually getting overcompensated blood pressure meds. So here's how it works in general. This is our little training slide about what's going to happen if you're doing HomeMeds. So it starts with that medication inventory and assessment. There's medication, entering the medications and clinical information into the computer. This can be done in the home if you've got a tablet or some kind of internet connection, or it can be done back at the office by a lower cost clerical person who has been trained in recognizing medication information. Then if there are alerts, and generally we find about 50% of folks whose records are entered into the system have alerts. It depends on the population. The more well and vigorous the population, the fewer alerts, the more multiple chronic conditions and frail. Obviously, the more alerts because the more medications they have. In the early stages, we ask the care managers to go back and confirm that the medications that are involved in alerts are actually being taken. And assuming they are, then we go on to a triage by the pharmacist who reviews the whole patient record that we have. They usually just log into our software and take a look at it and then decide whether it's an issue for, no, this isn't an important enough problem to intervene about at all, or yes, this is important, but we can deal with it just by talking to the patient and the family and advising them about the use of over-the-counter medications, or whether it needs to go to the prescriber and for a full medication review and change in medication regimen. The pharmacist usually is the one who contacts the prescribers. It can also be the care management agency, whoever is sponsoring the intervention. So if it's a medical group, they may wish to do it themselves. So we try to make it as close as possible to a peer relationship with the prescriber. So doctor of pharmacy to doctor of medicine, that kind of thing can be the most effective. And then we track the status and the MD response. If we get that, wherever possible, we try to check if we don't hear back from the prescriber, we check back with the patient to find out if they've had any medication changes, and then we document those changes back in our system. Are we getting any questions yet, or should I just mush on?
We have not gotten any through the chat function yet, so I'll just ask folks again to feel free to chat if you have questions, but please go ahead, Sandy.
All righty. So the pharmacist is an important member of the team here. Remember, they're not going into the home. In fact, a lot of these pharmacists are doing the work at night, in the morning, in addition to their day job. And it's a very convenient way of making the most out of the time of a pharmacist. So they're going through any alerts and screening them to confirm the problems. If the agency that's implementing this has nurses, they can do a lot of the pre-screening. But if it's a social work agency, then they rely very heavily on the pharmacist for pretty much all of the clinical aspects of this. Like I said before, they're communicating with the prescribers because it tends to be a doctor-to-doctor relationship. They also consult with the staff. These agencies just love knowing that there's a pharmacist they can call if they have a question about their client's medications. So that relationship is extremely important. And of course, if they're looking at the patient's record and see problems that aren't among those 4 that I identified, because we had a philosophy in choosing those, but once the pharmacist has the information, they're certainly going to say, oh my gosh, and they're taking these 2 medications that, given everything else I see on the list, probably aren't a good idea, and I'll make a recommendation about those in addition to the protocols that are part of the HomeMeds intervention per se. They also assist with complex cases, so that's where they're stepping in and doing really comprehensive medication review and medication therapy management. And we are starting to work with some companies to try to get this reimbursed by the Part B as part of the new approaches that they have to medication therapy management. They're also most of the pharmacists are doing in-services for the staff about geriatric medications, prescribing risks, those kinds of things, which the staff loves. And of course, all the staff take it home to their own families and apply this to their moms and grandparents as well. And on average, the intervention on the part of the pharmacist takes about 20 minutes, which can range from 2 minutes to say, nah, this is not a big problem, and just resolve it by saying this isn't an issue we need to do anything about right now, to an hour that takes talking to the care manager, talking to the patient and family, talking to the prescribers, so there's a wide range, but the average is about 20 minutes per client, per patient. So we have software. I didn't think that we necessarily wanted to go through a complete demo right now. So I had put in a picture, but apparently I can't play it. So we'll just, it's a picture of me using our software with my mom's iPad. So here are a couple of screenshots of the software. We start with a dashboard that tells you, what activity has there been, what kind of alerts have you seen. You can click on these as active links. So if I want to say, how many people have had an issue with falls in psychotropics, I can click there. This is the risk assessment in the software. So we have yes/no questions on falls, dizziness, confusion. We have pain. A lot of this information is background for the pharmacist. So if we said yes to falls and asked how many times, and it's 3, and they can't remember why they fell and they are getting injured, that's a different story from I fell once, my cat ran between my legs, and I haven't fallen since then. So it's a different, that gives the pharmacist the ability to gauge what's going on. They may decide that any fall is worth dealing with and just continue, or they may decide that one fall related to a pet isn't. The dizziness is sort of a proxy. A lot of our agencies can't take blood pressures, so it's somewhat of a proxy for that orthostasis, the dizziness and standing up and having your blood pressure drop. But it's also a side effect of many other kinds of medications. So we have a generic alert for dizziness that pretty much indicates that this patient should have their meds reviewed.
And Sandy, I just want to let you know we probably have about 15 more minutes for the presentation.
You got it. Okay, so how much pain? Again, these are background information, and so it's the blood pressure, falls, dizziness, and confusion that trigger alerts. We have a nice medication library that lets us pick only existing medications. Then we get a report that gives a complete list of the medications, nicely printed, which we give to the patient sort of in a self-management support style, asking them to take it to every doctor that they have, including their ophthalmologist. And then we get alerts that indicate what happened and what medications might be related, and the pharmacist can then intervene on those kinds of alerts. So there's duplication alerts and then the other programmed in alerts. The typical kinds of problems that we find, dizziness, and these are real, by the way, I'm not making these up. A patient with dizziness who has taken 2 beta blockers, a patient over age 80 taking 3 different medications that increase the risk of GI bleed, a patient who is falling and taking 5 medications that increase risk of falls, one taking 4 different narcotic painkillers, and our average person is taking about 11 medications, but we see up to 28 and probably more in a single patient. So our consumers are very grateful for this intervention. This is a man in Texas who was on 20 medications. He said, well, my wife just kept on bringing them with my coffee, and I took them. And finally, the HomeMeds folks came in and got him down from 20 medications to 8. And he was appreciative of the money he saved, and, oh, yes, and my life. The clinicians are grateful about this. We had a pharmacist who said she called the doctor's office, and he answered the phone, which was uncharacteristic to begin with, and then found out that this 96-year-old patient of his was falling, taking aspirin and Advil, and that the physician assistant was refilling Valium prescriptions, and the MD wasn't even aware of it. So here's this poor 96-year-old taking Valium, 2 different kinds of painkillers that are gastro risk and things that are fall risks. So really bad situation. Our users, the sites that are implementing HomeMeds, find that the seniors that are living at home, especially without supports, get the greatest benefits. One of our users said that, it's interesting where people keep their medications. They're taking their spouse's meds. They'll remember a medication bottle on the medicine chest or the nightstand. You wouldn't get that information unless you're in the home and can talk about it. So that's a very important aspect. We're not saying that it's not good to do, the brown bag kind of approach, but it's best to do an in-home assessment. Patients and prescribers give positive feedback about just having that comprehensive medication list, and hospitals, health plans, and community providers recognize the problem and, again, express their appreciation. And then the family caregivers, they feel so much more in control. They get a better understanding of their loved one's medications. They have that access to the pharmacist, and we're starting to teach people about how to advocate for themselves. And then we love Fort Worth, Tarrant County AAA. If you know much about evidence-based programs, A lot of them are very difficult, and they consider that our HomeMeds is the easiest of all the evidence-based programs. They see results, they're having fewer falls, and people are reducing their medication burden. So we have folks all over the country using this in Medicaid waiver programs for dual eligibles, care transition programs, and yesterday one of our sites did a presentation to the CMS group, and he reported on they've done 1,500 of their care transition patients. 42% of them had alerts in the system. 27% of all of their care transition patients have had medication changes that they've verified. So that's about 15% of the care transitions folks are getting medication regimen changes as a result of their doing HomeMeds with the intervention. We also have lots of community-based organizations. We're starting to have direct contracts with medical groups. Meals on Wheels, they're going into the home. Why not look at medications as well as nutrition, home health, home care, assisted living, affordable housing. We even have a little tribal community. So we're starting to do more innovative applications, a targeted one-time home visit by a social worker under contract with an at-risk medical group. They're doing a general safety assessment and the HomeMed screening, so they're looking at doing a PHQ-2 or 9 and looking at ADLs, their environment, cognitive status, caregiver support, and then feeding back all this information into a care plan, getting the pharmacist involved, and then making referrals for community services. So they're starting to pay the social service agencies to do these home visits. Just, if you're interested in starting up a home visit where there is none, we've looked at some potential targeting criteria. So we were looking at folks that are over 65, have been in the hospital or used the emergency department, and have fairly complex medication regimens, have use of psychotropic medications, mild cognitive impairment, risk for gastrointestinal bleeding, things like that. Another innovation, which is really lovely, is that the local fire department looking for frequent fallers, they're mapping them and targeting matter of balance, which is another evidence-based program with HomeMeds to decrease the burden on the fire department for running out and picking up folks off the ground, and rather than just picking them up and going back a couple days later, we're providing an alternative to 911 and getting people better rather than just doing the most immediate kind of thing. On Meals on Wheels, which is a homebound population, we've been finding 80% of those folks are having alerts, and out of the first 400, 180 had at least a fall, one fall in the last 3 months. We're also integrating this with the chronic disease self-management program and matter of balance, and with care transitions intervention. So in addition to the highly structured evidence-based programs, we're adding a medication risk assessment and the HomeMeds so that they're learning how to be better consumers of health care, and we're giving them something to talk about with their pharmacists and physicians if they have some issues that need to be addressed in their medication safety profile.
Sandy?
Yep.
There's a question that I think relates to one of the examples that you just gave.
Great.
Which is that there's an individual asking who pays for the pharmacist for each intervention and where is the software available. That person indicates they have a local fire department using their paramedics to drop hip fractures by over 80% due to home assessments, and thinks that tool could be valuable for them. So in the case of that Tarrant County example with the fire department, do you kind of know how the financing worked for that?
Generally, these agencies are using Older Americans Act funds to pay for the pharmacist. We're starting to experiment with getting Part D to pay for it. Others have, there are some volunteer pharmacists. There are others that are, you know, using a commercial relationship to pay for it. Schools of pharmacy are using their students under supervision. So there are a number of ways that it's being approached. I could put them in touch with parents to make sure. I know that they're using their Older Americans Act funding. I don't know if that's the only source of funding for it. And of course, in care transitions, they're getting a bundled payment for the whole service through CMS. So I know that a number of them have worked in the pharmacist services into that also. The software, it's completely online. My contact information is at the end. I'd be happy to connect them up. It's not, you know, you can't, because it's a secure HIPAA compliant software, you can't just see it per se, but we'll be happy to demo it and walk somebody through.
Okay, great.
Great. So when we get somebody started, we do a whole planning process because a little different from many other so-called evidence-based programs, we have a lot of adaptations and places where we are a little flexible. So we do a planning. So we look at the readiness, make sure that it's not just the executives, but the supervisors and the people that are going to do it that are excited about it too. Make sure there's champions because it's still a practice change for everybody. And then we're introducing computers sometimes to folks that aren't really used to them. You can plan how data entry is going to happen. One of the comments that we get is we're afraid of liability, especially social service agencies. And there's, you know, in thousands and thousands of patients that have gone through this intervention, I mean, probably 15,000, there's never been any liability. But also, you know, a social service agency is there to collect information and to transmit it to the right people. You're not responsible for the behaviors of prescribers or the behaviors of patients. So, you know, it really is not a liability issue as long as if you discover something, you do something about it. Then sometimes they face a little bit of, oh, I trust my doctor. So we have materials for consumers that talk about, you know, you're going to get this beautifully printed list that you can take to all your doctor's appointments. Your doctor will be very grateful, and they don't always know what other doctors are doing for you. So we have, but we do recommend that, you know, if possible, if you're dealing with a frail population, that you kind of do it as part of a standard practice. It's not as much of a problem with somebody who's capable of seeking out information about their medications because they're usually asking for this. What does it cost? We are planning set up. You know, we've got a pharmacist who works with us to set everybody up. So, you know, that's $3,000 is our usual charge. Then the license, it's a little bit adaptable depending on your volume, but we tend to charge $200 a month for up to 50 new clients put into the system. We don't charge on a per user basis at this point. And then we let smaller groups gather together into a single license and do some, you know, we want people to do the work of medication safety and the work of HomeMeds, and we will do what it takes to make sure that we're not pricing anybody out. So, you know, for example, we do on-site training. We go out there, we'll train 25 people from 5 different agencies and have done that. So sharing the costs is absolutely perfect. And then after the first year, we just charge a very small amount for refresher webinars. In the first year, you know, if you need a refresher webinar once a month, we do it as part of our initial charges. And this kind of answers the other questions. The Older Americans Act covers a lot of the expense. Pharmacy school waiver purchase of service dollars can cover this for people that are Medicaid eligible and in that nursing home certifiable community dwelling population. I think I've covered all of this. So I'll whip through. So HomeMeds is a proven tool for improving medication safety for older adults, and it's an affordable, evidence-based program that's a perfect bridge for partnerships between community agencies and healthcare. Questions? And that's our contact information.
Great, thank you so much. And so I'll just let folks start chatting in questions as they have them. And then one thing before we start answering questions, there is an exit poll, so for folks who may have to exit the webinar, please take a moment to answer the 3 poll questions that are on the right-hand side. And again, you might have to expand the polling section if it's been minimized because of the chat function. So I'll ask one question as folks are kind of thinking about how this program might work internally for the various types of organizations that they're representing. But I imagine that, these innovative applications that you listed previously, where it seems to be kind of modules, I guess you would say, is that how you would characterize them? They're sort of sub-modules of the larger HomeMeds program. How much uptake have you gotten of the different innovative applications that you listed there, and in what kinds of organizations do you see them working at this point?
Yeah, I have, we have probably in Los Angeles, we've got 2, well, we have care transitions interventions that are doing it. Some of them private paid for a health plan. I guess I won't name names if you don't mind. But and then some of them through the CMS care transitions initiatives that are going on around the country. There are about 5 of our sites that are doing care transitions, but they're still community-based organizations. Typically, the work is done by the community-based organizations, and it's done in the context of payment and relationships with healthcare providers. So a community organization will go and do a home visit and then charge a capitated medical group for the home visit and the HomeMeds intervention, including the pharmacist. I'm not sure I've answered it, but that's been our primary target. I think one of the challenges is integrating our software, so we're doing a reprogramming now to make sure that it's easily integrated with electronic health records. As those become more heavily used, we need to have the efficiency of being able to upload and download information to and from various systems. So that's where we're heading our efforts now, so that kind of anybody can do this and have access to it within their existing software, which will expand the reach of it. Right now, it's because of the incentives created by the Administration on Aging and Administration for Community Living that we have a particular audience that's doing it for the most part now.
Okay. And then the training that you do on site, is that a one-time training?
Yeah, we usually go for 2 days and give people an opportunity to kind of process, and then the second day is more of a question and answer type of thing. So we usually send 2 people, to the pharmacist to deal with the clinical, and then someone who's experienced with using it in a real organization to talk about there's always challenges to adopting a new practice. So we talk about what has happened in the past and how other people have successfully gotten around the challenges and made a success out of the program. So that's one time. Unless they're ready to start the next day, we usually wind up doing refresher webinars, a couple of those over the next month or 2.
Mm-hmm. And given, all of the interest in the dual eligibles population, I wonder if you could comment a little bit about, you said that some Medicaid programs are using HomeMeds for duals. Could you talk a little bit about what that's looked like?
Sure. In a Medicaid waiver, I'm going to use California because it's the one I know. The Medicaid waiver program essentially pays for two things: care management, that deploys all of the community resources that it takes to keep a very frail person at home and out of the nursing home, out of the hospital, wherever possible. And so there's the care manager, and then there's the extra services. So they'll pay for a ramp. They'll pay for anything that Medicaid doesn't normally pay for or that Medicare doesn't normally pay for that helps the person stay independent. Sort of the panic button, emergency call system, ramps, hand bars, respite care for when they have a caregiver that needs to go out and do something. They do assisted transportation. I have to go to the doctor and somebody's going to pay for the transportation. That source of funding that can supplement the normal Medicaid and Medicare services can pay for the pharmacist review for HomeMeds. So because most of these programs are required to collect medication information, and what we found, which was sort of appalling, was that they collected the information and stuck it in a folder and did nothing with it. So we're saying we've taken the time and the effort, we've got all this information, let's do something positive with it. And so that's part of why we're so kind of, I'll say, rabid about putting HomeMeds into programs like that, where folks are going in the home and spending that time. Let's just add this one small piece of it, and then we make something much more out of it.
Great, thank you. And so I don't see any other questions in the queue. So folks on the phone, if they wanted to learn more about the program and how it might be integrated with what's going on in their organization, you would be the right contact on this slide, right?
Absolutely.
Okay, great. And her email is there. Thank you, Sandy, so much for joining the call today and sharing your work. And as folks are signing off, please take a moment to answer the polling questions on the bottom right. Thank you again, Sandy.
Thank you so much. It's been a pleasure. Thank you all for spending time with me.
Have a great day, everyone.
Bye-bye.
Bye.